You're listening to Just Medicine, an equity in healthcare podcast created by medical students in British Columbia.
Hello everyone, welcome back to Just Medicine. My name is Zoe and I'm a second year UBC medical student and I will be your host today. I will be speaking with Bryan Becker and I will give a brief introduction for him before we get started onto our conversation. Bryan Becker was born in Vancouver, BC. He is presently working as a peer support worker at the RAAC clinic at St.Pauls Hospital. RAAC, or RAAC, stands for Rapid Access Addiction Clinic. This service provides addiction medicine assessments for any substance use issue, including alcohol. It serves to maximize treatment support for clients, provide training and distribution of Take Home Naloxone, offer harm reduction services, and to facilitate referrals to substance use services. Support workers like Bryan are individuals with lived experience of mental illness or substance use who have graduated from a peer support worker training program. These individuals work on a contracted basis under the supervision of rehabilitation staff with clients who access Vancouver mental health and substance use programs and services. On his own time, Bryan enjoys BMX, the beach, Third Beach Drum Circle, movies, reading, and helping others. I am so honored to have had the chance to speak with Bryan, and I hope that everyone listening takes away as much as I did from the stories and the advice that he shares with us. All right, so thank you so much for joining me today, Bryan.
You're very welcome.
Amazing. So I think we can start off just really general, broad questions. So first off, can you start by telling us a little bit about yourself and your story?
Okay, so my name's Bryan Becker. I am turning 49 this year. I was born in Vancouver. I was adopted when I was 6 months old. I lived up in 100 Mile till I was about 17 years old, so I kind of lived a little bit of a small town life. Things were a little boring up there at times, so that kind of pushed me into kind of a bad area of life, just kind of out of boredom, smoking pot and getting into other drugs that are typical of small towns. I've been to college. I went to college for IT stuff. I completed that. I'm presently working as a peer navigator at St. Paul's at the RAAC clinic. I also do urban health training and trauma, violence, and informed care training with Naomi Watt at St. Paul's as well. She was a nurse that I met when I was on 10C, probably 4.5 years ago now.
Thank you so much for that. And can you share a little bit more about your journey to becoming a peer navigator at the Rapid Access Clinic and what exactly motivated you to pursue this role?
Sure. So I've always been told ever since I got into the drugs years and years ago, during my clean times, people always told me I would make a good counselor. So that was something that I was considering. I find it quite easy to talk to people. I find it quite easy to connect. I feel that I'm able to hit people in that area where they feel like they want to talk with me. So experiences from my addiction kind of put me in a prime position of understanding, and the dynamics of our clients are that I recognize the suffering that they're still going through. I wanted to help anyone that was experiencing similar trials because the ones that I experienced were pretty bad. And if people had even half as bad or twice as bad as me, I feel that that put me in a really, really good spot for them to relate to me. It is possible to get through the worst of it, start fresh, and live a meaningful life. And that is kind of the message I try to push on to my clients.
Mm-hmm. And I mean, you might have already kind of answered this, but what exactly inspired you to work in the field of addiction support and recovery? Like, was there a certain moment or a certain mentor or someone that really got you into it?
There was actually a few. So, like I said, I was up on 10C, and I was like one of those problematic patients that was always missing antibiotic time. I was always there for my painkillers. I was constantly getting discharged or leaving against medical advice. But there was a group of nurses up there, Naomi Watt, Carlin Patterson. There's two others too. They were there, and they were quite. they had kind of had enough of my bullshit, and they'd started putting the idea of taking responsibility for my life into my head. So during my last stay, I was there with endocarditis and I was quite sick. Um, and they kind of got me motivated to just flush out the street drugs and I started using Cadian morphine. And it took about a week of kind of feeling crappy going through withdrawal, but it put me into a place where I felt like I could have a clearer head. I tried to get on the heroin program and I had my foot into the door for that because as an addict, that would have been my dream at one time was to have heroin for the rest of my life. But I didn't want to be stuck um, going down to get a fix 3 times a day.
Mm.
So the folks at the hospital, along with the social workers, they helped get me into treatment. I went to treatment it was called CCL Lodge at the time. It's now known as Emerge Treatment Center. I went there for 3 months and I did secondary recovery at Belkin House. Met many people there along the way. During that time, I got in touch with the STOP team, and they were the ones that really, really kind of pushed me in the end to apply for this job. I had already kind of met all the expectations that I could meet as a client for them. They couldn't help me anymore. So there was a day that they said, well, we feel we have to discharge you because, and I was actually quite hurt because I was like, well, I don't want to be discharged. I felt quite comfortable. But they said, no, no, it's a good thing because we think you're in a place where you can start to move on with your life. They told me about a job position that was open up at what was called AIDS Vancouver, which is now called Ribbon Community. There's a whole bunch of name changes in here. Um, so I applied for that job and I waited for probably about a month or 5 weeks to hear back from them. I went in, sat down with them, and they said that I was exactly what they were looking for. They wanted somebody that had experience, in the streets, drugs, prison, the whole shebang. So to sum it up, social work, nurses, and the doctors here, Mark McLean was amazing. At the STOP team uh, and Emerge treatment, they were the ones that really pushed it in.
Thank you so much for sharing. It was really interesting to hear about sort of the different steps along the way to recovery, and I think it's really good for us to know sort of that extensive process and how you ended up where you are now.
Of course,
So as a peer navigator at the clinic, as you mentioned, can you touch on some of the main responsibilities or tasks that you do there?
absolutely. My main one is advocating for the clients. Quite often, clients feel unheard. I feel it's my job to help represent them when they can't represent themselves. So advocating for them and their needs is huge. I help with appointment support. I help with emotional support, social support. I collaborate with client and healthcare professionals. So that means sitting down with nurses and doctors and social workers, either all together or separately, and discussing client needs case by case and seeing how we can help them because I seem to be able to elicit a little bit more information. They get comfortable with me a lot quicker.
Mm.
Yeah, which is great. So I help them with treatment options, shelter options, um, also just being an intuitive listener. They want to be heard. Sometimes they just got a story that they need to get off their backs. A lot of our clients are suffering horrible traumas every day.
Mm.
The amount of young female sex workers that come in is really, really heartbreaking.
Mm.
Or these guys that are coming in all beat up because they've been robbed, because they're an easy mark. Or I know one that was beat up for being gay. It's just a horrible situation. I also accompany clients to detox and to treatment facilities. Those are my main areas, but I do break it down a little bit more. So I kind of do what I need to do when I'm asked to do it.
Right. And so with this position, I think it's a really unique position. And I know that, as you said, there's a lot of things that you've experienced in your life that have helped you sort of fulfill this role to the fullest potential. So
Mhm.
can you touch on like how those experiences, whether personal or professional, have prepared you for the challenges and also the rewards of this position?
I haven't had much professional experience other than the 3 years that I've worked at RAAC. It's been a learning curve the whole time.
Hmm.
I didn't get the same type of education to work in the healthcare system as other people.
Hmm.
And at that point, I was only about 20 months clean. Um, so it's kind of like a big culture shock to go from, the violence and drug use and just everything that goes on the streets and in jails to suddenly you're in a place where you're expected to not lose your temper or, speak in a correct manner and not swear all the time and everything. But we say that swearing is the love language of St. Paul's, so um, I kind of benefit from that, I suppose. But it's mostly been the personal things like the time in prison, the short periods of homelessness, years of using drugs every day, and all of them. Like I was a person who pretty much tried the whole gambit, pills, GHB, powders, you name it. Time spent in the hospital being sick from things like cellulitis, flesh-eating disease, endocarditis, abscesses. It hasn't been an overly challenging job because I find that my life before has provided me with a lot of adaptability, a lot of resourcefulness, and the managing of expectations on how help looks in the healthcare system for substance users. I think that that's probably the biggest thing is helping manage expectations. And that was probably one of the harder ones for me to adapt to because I came in with a little bit of a chip on my shoulder. I see people in the hospital that used to treat me quite poorly.
Hmm. Can you touch on actually, I don't know if you feel comfortable, but can you touch on how that transition from being the patient in this situation and receiving treatment to being sort of on the other side and having all those complicated relationships in the midst of it? Can you touch on, how that's been for you?
It's been a little bit difficult. I'm an employee here. I'm a contractor. I'm not hired by Providence, but I am a contractor for Providence through Ribbon Community. So I basically get the card to swipe in to the doors like everybody else. The big difference is I get to wear my street clothes.
Hmm.
So when I'm down in places like the emergency department, quite often, not so much doctors, but a lot of nurses will come up to me and ask with kind of a snotty tone, like, what are you doing here? Why are you here? And quite often I just kind of have to bite my tongue and hold up my badge and say I'm employed here. Or I've been called down. Like I work closely with AMCT, so they call me down to ED quite a bit. Same in other places like PASU, ABSU, all that. It's so I feel like I may stick out like a sore thumb every once in a while, and it does catch the attention of some people. And I would like to make clear that it's a small percentage. Most of them are very, very welcoming and are very supportive of having um, somebody like myself down there to help with somebody that they may not fully understand.
Hmm. It's very, very valuable. And I know even just from my short experience working with some people who are struggling with substance use, I know that it will be very helpful to have someone who has a lived experience so that I feel like they really can be understood. So, kind of along those lines, how do you approach building the trust and rapport with the clients who come to this clinic? And how can we learn from you in that way?
Simple introduction to start with, tell them who I am and why I'm here. A lot of them ask if I volunteer. Some of them actually get kind of turned off when I say that I'm employed because they feel like I've suddenly jumped teams, if that's the way you'd want to put on it. But I tell them, no, 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 I'm here for you. I'm here to help you, and I want your stay here well while we're trying to help you to be comfortable. And it's not always comfortable because they're always going through horrible withdrawal, or they've lost their place, or again, they're experiencing violence or anything like on the street. So I invite them to dialogue with me about whatever they happen to be visiting the clinic for. I try to follow through with any kind of work that I promise to them. I find that any type of broken promises is broken trust right away. They will be hesitant to ask again for anything. So if it's something as simple as, can you please get me a bag lunch, and I forget to get them a bag lunch, that is actually quite harmful.
Mm-hmm.
So I try and stay on top of things like that. And I admit I do. There are times I'm so busy that I will forget, and I'll have to take the heat for it, but I'll own it because I've been there too.
Mm-hmm.
Um, it breaks that trust to say you'll do something and not do it. I also make sure that I'm coming across to the clients in a sincere manner and making them feel like I'm not being fake towards them. And I'll elaborate on that. I've seen a lot of nurses come with kind of almost like baby talk at them.
Mm-hmm.
Oh, how are you? Are you okay? That type of tone. I can tell you right now. I mean, even I wouldn't like to be spoken to like that now, let alone if I was going through withdrawal or being in a miserable situation. They also can tell when people are being extraordinarily fake. Like either treat everybody the same, or it's just that's all it is treating everybody the same. Because if they see you being nicer to somebody else, that's what happened to me quite a bit. I used to see people being treated better than me because I was that junkie that was laying on the table, you know, or on the bed, and they weren't. So I felt like I mattered a little less. Um, Clients are very adept at knowing when people are being fake towards them. Um,
Mm-hmm.
the time that they spend in that life puts them in a lot of situations where people are lying or not representing who they really are. So that's where I find it most important to be as genuine as possible. My own past also serves as a connection point for clients to build quality relationships. They understand that I have their unique perspective on what they're going through, something that most, but not all, nurses and doctors don't understand. I mean, I know that we have some nurses and doctors that have experienced alcoholism or drug addiction. And I can't honestly say that I would know the capacity that they've suffered in, but there is definitely a unique clientele that comes into our clinic where they're kind of like at the bottom there. They're fighting just to stay above the bottom. And it's a difficult situation for them. So simple things like offering them food or clean clothing, it really helps to build trust. I mean, some people haven't showered in 1, 2 weeks. Their clothes are like literally falling with dirt, or they have blood all over them or something. And you know how good it feels to get that clean pair of socks or fresh underwear, pair of pants on your body. So you don't feel like you're just like stinking or whatever. I've been there myself. It's not a good feeling.
Mm-hmm.
Um, and they associate the act as generosity and somebody actually caring about them. So
For sure.
it's good to know that they are appreciative of that.
Mm-hmm. Yeah, thank you so much. Those are all really good points. And I think as much as you can, as the peer navigator, do them, I think all of us can learn from that and definitely take some of those messages with us. So my next question is, I know at the clinic you mentioned there's so many different sort of healthcare workers. What are some of the key ways in which you collaborate with all the other healthcare professionals to provide sort of comprehensive care to the patients?
Probably the most surprising is working directly with the physicians in the clinic. Quite often, I've been asked to go talk to a client and they will ask what my perspective of their withdrawal symptoms are like. So I'll give you an example. Something that happens quite often is people that come in with alcohol withdrawal are quite often shaky. They haven't slept. they're very, very anxious. And one of the main treatment methods is obviously giving them benzodiazepines. If I can help them get something like that, I will go talk to the doctor and I will say, listen, this patient may benefit from an extra 10 milligrams of diazepam. And most often, I think that the doctors are quite happy to do it. They'll know if somebody's for drug seeking. So if they're comfortable with that, I think that's really cool. It was one of the things that probably surprised me the most when I started working here was that type of collaboration with the doctors. They get me to talk to the clients because clients are often hesitant to provide the full information too. And sometimes when doctors have asked me to go speak to them, they have gotten completely different stories. So they were told one thing, and I will come back with, you kind of got to read between the lines to what the truth is. So one version, another version, and then you compile the information and make a decision from that. So it helps that that I'm able to get that information from them. Nurses do the same thing. They quite often ask me to help with that.
Mm-hmm.
In many cases, the clients struggle with trust factors, which causes them to shut down and share less. And that's definitely, it works as a disadvantage to us because we want them to be as open as possible. As I said, I work with AMCT. I quite often go down to the emergency department and speak with clients or accompany them up to the RAAC clinic, where we will further discuss what's going on in their life. Additionally, I work with social workers and other peers where we co-facilitate a contingency management group, which is for substance use. It's reward-based change. So we offer gift cards for people that come in, and we've got a pretty good group. And I'm actually really surprised at the power of gift cards has to keep people clean, because we offer a voluntary urine screen, and if it comes back clean for stimulants, they get an additional draw for a gift card. And a good majority of them are actually coming back clean. I would say at least half the group right now, which is pretty good. This is my favorite right here in collaboration. I work with a very special nurse friend, like I said, Naomi Watt, and I help her every month with urban health education training and trauma, violence, and informed care. So Tuesdays, Wednesdays, and Thursdays, one week, the second week of each month, we get together and help the new peers, the new nurses, the new nurse practitioners, and the new social workers that are coming into St. Paul's or Providence, I guess, maybe even Vancouver Coastal. I think we've had a few. And we go over everything that kind of urban health has to offer. So I guess it's effectively, urban health is probably about a 16-hour course, and then trauma, the TVIC one, is about 4. And this collaboration means a great deal to me because it's putting me beside the people that once helped me. So it
Wow.
makes it even that much more special.
Mm-hmm. That's such an amazing story. Thank you so much for sharing that.
You're
I'm so
welcome.
happy also that there's that training, because I think it's so important that we really make that available. So thank you for telling me about that.
It's actually mandatory now.
Even better. So that's great, and I'm looking forward to hearing more about that maybe later. So how does your lived experience inform and shape your approach to supporting clients at the clinic? And especially, how do you think that this differs from the other healthcare professionals who work there?
Okay, so as I've got here, I've lived through the proverbial gutter, which most nurses and doctors haven't. This helps shape a unique perspective of what our clients could be dealing with when they walk through our doors. Um, Understanding the needs of people that are coming from the streets or prisons, or even coming out of treatment centers or anything like that, or like detox. Understanding the homeless situation, understanding what goes on with the abuse of different types of drugs. Um, I think a good example of that would be like crystal meth users are always talking about being followed and people hearing their thoughts and things like that. And there's a word out there that's used quite often called gang stalking. This comes up quite a bit in the clinic. And this is something that I'm personally familiar with because I suffered from it myself. It's a horrible level of psychosis. Um, these poor people that are coming in are utterly convinced that everybody around is following them or talking about them. And I've got a client who is actually a 20-year friend of mine also, who has bear sprayed people. He has violently attacked people. And I always try and make it a point to be here when he comes in because I have such a great degree of success de-escalating his feelings. I don't ever tell him that it's not true because telling them things that go against what they're believing at the time is being argumentative, and
Mm-hmm.
it really doesn't help the situation.
Mm-hmm.
So just kind of I guess what it amounts to is a little bit of coaching
Mm-hmm.
and giving them that understanding that I know how you're feeling, because quite often they will say I don't know what they're feeling, but the fact of the matter is I get it more than anybody. I mean, I've personally been put in psych hold 6 or 7 times in Victoria from psychotic meth use. Just too many days awake. It it, it catches up, right? It's having a different and more intimate understanding of our clients and their needs that puts us in a better place to help them. It's difficult for doctors and nurses to relate to that because I don't know many nurses or doctors that go through the hell that some of our clients go through. It's definitely a situation that not many people experience or would even want to experience. It gives me the ability to prioritize their care a little bit, and it helps with my ability to see their motivations, their fears, and what their priorities are. Like knowing what they want, knowing what they're scared of, and knowing how they would like to pursue is huge.
Mm-hmm. Yeah, thank you so much. And I think that really perfectly ties into my next question, which is a bit more specific. Can you share a memorable experience or success story that you have from working as a peer navigator?
Yes, and I love this story so much. Uh, I won't use his name, but there's a client that we have. I used to know him from the street, um, not well, but enough to say hi or enough to say, hey, can I get a dragon off you when I was still using or whatever. When I started working here, I started seeing him come in, and he came in quite often with a huge chip on his shoulder. He was always angry. He was always upset with the help, never wanted to wait. The prescriptions were never good enough. It was always, and I say this in a loving manner because I love him. He was an absolute nightmare to deal with. But I sat down with him one day because I found out that he had a recent diagnosis for HIV. And being that I work at Ribbon Community, I've got a lot of experience with that. And I wanted to sit and talk with him. So finally, after a month of looking for him, I see him come in and we sit down. And sure enough, right off the hop, he's in his cranky mood and everything. And as peers, we kind of have a bit of a different way that we can react with our clients. And a nurse or doctor would never get away with saying this. And I just said to him that day, and keep in mind, it sounds harsh, but it is coming from a place of love. I said, why do you always act like such an asshole when you're here? And he looked at me and he's like, he goes, well, I gotta. He says, this is my space. He goes, if I show any type of weakness or whatever, he says people are going to start walking all over me. So he carries this attitude on the street, everywhere he goes, into a store, into a hospital, because he's so scared that people are going to walk all over him or hurt him. And it was heartbreaking to hear. And it was also probably one of the most honest things I had ever heard from a client. I was just kind of sitting there dumbfounded, going, oh my God, like I took my shot in asking him in that way. And it really seemed to um, solidify some type of connection between him and I. Like it kind of put a newer feel on it, because I told him after he had told me about his shield and everything, I was like, I get that, bro. Like I absolutely get that. And I said, I would appreciate it if you could maybe lower your guard a little when you're in here and let me try and help you. And, if you're having troubles with nurses or doctors, you ask for me. I will come and sit with you, and I will make sure that if you feel like you're being treated with disrespect, that you will be treated with respect. Or if you feel uncomfortable, that I will make you feel comfortable. Or just be there for support. I was coming down from a contingency management class or a group probably about 3 weeks ago. And he's up at the JRC clinic because he's a patient up there now. And I saw him because I hadn't seen him in a while. And I was like, dude, it's great to see you. He was like, he says, come here, I got something to tell you. And he says to me, he says, I just wanted to thank you for sitting me down that day and having that chat with me. He said, because it really made me feel like I was like heard and human, and that my life was not over, because his HIV diagnosis really scared him. He's like, I'm never going to get laid again. And I was like, well, that's not reality these days, buddy. There's tons of positive, negative relationships out there. I know there's a word for it, but I can't think of it. And just going through all that information with him, I think really soothed him. And I could tell that chat had motivated him. He had been taking his medications, his clothes were clean. He had probably gained about 25 pounds, and he looked really good. And that one has always hit home with me. I actually just used that in a thing for my boss because they wanted stories of positive interactions. And I think that one is probably one of my favorites. I've got others, but that one I think means the most.
The power of honesty and also just getting it at his level, I think. And also so reassuring to hear that, he is doing better. That's amazing. And I hope that
Right?
keep seeing him in that way and he keeps on the up. And yeah, HIV for sure. I think, there's a lot of stigma around it, but actually it's very treatable. And I actually did a podcast about that as well. So interesting.
Oh, great.
Yeah. Okay. So thank you so much for that story. I
You're
really love
welcome.
hearing that. And then I just want to ask one more question about the services that are provided. So in your role, like how are you making sure that the services provided are client-centered and that they're responsive to sort of the diverse needs of individuals who are seeking support for addiction?
So starting by listening to the client's needs. As a peer, I translate for both sides, healthcare and client. Every person is different, so allowing the client to explain how they are feeling, or having a peer translate for them, um, and making it less about just filling out a form, because there's something really cold and clinical about just ticking off boxes in a manner of, it's got to be done, but it doesn't always have to be done in a way where people just feel like they're being studied, you
Mhm.
know? Um, it's important not only to listen, but to only interrupt when absolutely necessary. Sometimes you got to interrupt to keep them on track because they do tend to tail off, especially if they're going through psychosis or they've got other things on their mind. Some clients have a very hard time speaking with anyone that would appear to have any type of power over them. Sometimes they just need to feel like they're being heard. One of our most common complaints is they feel like the doctors and nurses are not listening. This is where I can come in and advocate for them and build a better rapport. Uh, Being sincere in the manner in which you address the clients is crucial. Clients hate being spoken down to or talked to like a child. As I said before, our clients are very good at picking out the fakeness or insincerity of someone's voices. They deal with this on a daily basis. The follow through is always the huge one too. Getting them into um, any type of services outside of our clinic, whether it be treatment or detox, goes a long way. I feel like if we're getting them into these services outside, we're getting the better part done for them. It's just that they just have to show up and do the work. The services that I feel that we need to provide more of are definitely more beds for them. I feel that we would have much more success if we had a higher number of detox beds, treatment centers with more beds, because the wait times right now are up to 4 months. Detox, depending on where you're going, is anywhere from 2 to 4 weeks right now, I think. We're just opening 11 more beds in the hospital, and there's supposed to be 50 transition beds opening up in the community. But still, like, for the amount of people that are coming in on a daily basis, it's still it's being understated. Like, we need more, right?
Yeah. What changes do you think need to happen to better support people who use drugs in British Columbia specifically?
So again, more treatment beds, more
Mhm.
detox beds, more transitional beds, better recovery houses. And I will elaborate on that. There are so many recovery houses out there that all they want to do is get the social assistance check. And it's basically a farm of people going in and out, in and out. I've literally seen clients pay and then within 2 or 3 days suddenly be kicked out for drug use. You can note that I air quoted there. They come here and I will do a urine screen for them, and I will see that they have not used drugs. Yeah. And this has happened. I just saw a client in here today that it's happened to twice. He has paid his money, and then within 3 days he's been kicked out. He has come here, done a drug screen, and he is absolutely drug free. Not weed, not prescription, not nothing.
Wow.
And that, I think that would be like, so I guess more oversight for those recovery houses and shutting the garbage ones down. I actually went to one where they had split the bedroom into four by taking the closet doors out of the closets and building the closets into walls. So there was a bed and a bed and a bed and a bed, and then there were closets that were like dummy walls. I left. I was like, I'm not staying here. I'm better off on the street.
Yeah. No.
It was brutal. It's disgusting. So more safe consumption sites, especially for those that inhale their substances. There's been such a huge change from intravenous to inhalation. I think the recorded number is 60%, but I think that the actual number is closer to 70 or 75. We're opening up a tent on the fourth floor here, finally, but only after all this pushback that was just happened on the news, if you've been following any of that.
Yeah.
And of course, only after this has all come out and get pushed on in the news, they're going to hurry up and do it. This tent should have been up months ago. Might get in trouble for saying that here, but whatever.
Oh, it's okay.
I'll eat it. So more programs. This was a great one too. More programs like the Enhanced Access Program at the Columbia Street Clinic.
Mhm.
So fentanyl right now, they're finding a typical point, tenth of a gram is equivalent to about 25,000 micrograms. In the hospital, you can only get, I believe that the doctor said 4,000 micrograms at once of powdered fentanyl.
Mm.
So 4,000 micrograms isn't going to do much for somebody, but they are actually prescribing 25,000 micrograms to match the strength of street drugs at this enhanced access program. I think that would drastically reduce the amount of damage that's coming from all the toxic drug supply,
Mhm.
like people that are getting the stuff with the benzos and the xylazine, the people that are coming in with sores all over their hands, their arms, their feet, like their legs, you know, some of them actually just smell, and I feel so bad for them. They smell like they're rotting.
Mhm.
They're so dirty and so they just look so bad.
Mhm.
It's really heartbreaking to see it.
Mhm.
So I think along with that, more proper psychosocial supports and adequate mental health treatments to coincide with substance use. We seem to be lacking in a combined approach for that because so many folks out there are sick with mental health issues. I mean, and what are we doing? Like they're not getting any. They get held for they get certified for a day, then they're out. You know,
Mhm.
and there's no help for them. So I mean, it would be it would be great to see someplace big, like a proper hospital. I don't know what there is out there for right now, but like a large hospital to properly treat mental health and substance abuse. I heard that Riverview was doing something like that,
Mm.
but I can't speak too much about it because I don't know enough. It's just something that I had heard. Getting clients into proper housing faster would be a huge step. I find that people that have housing are doing a lot better than those that have to sleep in these encampments or in a back alley or whatever. Reintegration programs for people that are coming out of the correctional system too. Uh, they're these folks that are coming out of jail, their tolerances are really low, and they are at a high risk to die if they use. The fentanyl right now is just crazy. I mean, it's not like the heroin of 20 years ago, I'll tell you that.
Mhm. Yeah.
Yeah.
Thank you. Yeah. And I think all those are very good ideas. And I do think that, hopefully over the next few years, people do start to become more aware of the severity. But I do think it's been a very tough, at least from my perspective. I'm not sure if this is correct, but it seems, I've been reading on this for the past 5 years or so, and it's a tough sell, I think.
Yeah, you just took the words right out of my mouth. I was just gonna say it's a hard sell because some people just say, well, why don't they quit drugs? Well, gee, why didn't anybody think of that before? It's just not that easy anymore. There was a time when a person could use heroin and go through the withdrawal and not have to be hospitalized. They could just get a bag of candy and take a hot shower. Lots of sugar, lots of shower, so your bones and body don't ache, and you could actually do it. It was more mental back then, but nowadays the drugs, everything that's in it, especially the benzos, like I've never seen so many people that like dually hooked to benzos and opioids now. And it's
Mm.
all because they started putting it in there. I only ever got benzofentanyl twice, and that was basically right around the time I was really, really sick.
Mm.
And that was part of the writing on the wall that told me that I had to quit.
Right.
Yeah, I mean, I didn't want to go through it. I honestly feel like if I didn't quit back then, I'd probably be dead right now.
Oh,
Yeah.
yeah. What messages would you like to share with medical students who may be listening to this and who will most definitely care for patients who use substances or someone who may be considering using substances, as someone who has lived experience, what is it important for us to know as healthcare providers, future doctors?
Okay. Listen to your clients. Each client is unique and will present their own challenges. Know what withdrawal looks like of each kind. Familiarize yourself with alcohol withdrawal, with benzo withdrawal, with opioid withdrawal, any type of withdrawal that there is. I would say familiarize yourself as heavily as you can. Ask a lot of questions from the clients you talk to about what they're feeling, and I don't know, maybe make notes about it, right? And get as much information about that withdrawal as you can. I noticed that the newer doctors are really they're getting really keen on to seeing and knowing what the withdrawal is right away. I mean, they've been taught by some pretty good ones. Again, I'll mention Mark McLean because I have a lot of respect for that man. So yes, know the effects that they can have on each type of person. So look closely and listen to what the client is telling you and how they are feeling. Know your meds and know exactly how each one can help a client. Some meds, I will use Dilaudid as an example, may be stronger than, say, morphine, but it does not last as long. So a personal example of mine would have been I was getting about 160 liquid Dilaudid, but it was not lasting me more than 3 hours. But at that point in time, I was taking about 1600 Cadian, and it was lasting me over a day and a half.
Mm-hmm.
So I think that was part of the reason why the Dilaudid program was such a failure, is people didn't like them because they didn't last long enough.
Mm-hmm.
So knowing your medications and knowing exactly which ones will help the most, I think is really important. How long they last, and their effects, and know about addiction as much as any other issue that a doctor would deal with. So if they teach you a lot about, say, diabetes in school, and you know a lot about that, I think you should know just as much about addiction. Or
Mm-hmm.
if you know enough about cancer, addiction should be the same. It shouldn't be secondary. It should, if you're going to work in that field, it should be focal and first. And that actually came from a doctor. Yeah, I had asked a doctor, and that's what the doctor had told me. So,
Mm-hmm.
and I think that really hit home with me. Um, so learning the wide spectrum of harm reduction strategies and offer lots of solutions, because expecting abstinence isn't a realistic outlook. In fact, abstinence is probably the lowest on the totem pole.
Mm-hmm.
So knowing things like the contingency management or the fentanyl program or the enhanced access program, or, well, we used to have the Dilaudid one, or any type of oat or whatever, I think would be widely beneficial. Ways to use drugs, how to use drugs, like in the urban health thing, I teach people how the pipes are used, how they're packed, how needles are used, the whole process, so they know they can make a proper judgment, right?
Mm-hmm.
And finally, a realistic view of client issues would make the work clearer. Getting the understanding of what is making the client use would probably be first and foremost.
Mm-hmm.
The root cause, yeah. And there's going to be one or many in most cases. Again, there's going to be trauma. They could, intergenerational or sexual or violence or emotional, you name it. There's going to be something.
Mm-hmm.
So it's going to be a deep dig.
Mm-hmm.
Yeah.
Those are all very, very good pieces of advice. And I think I'll personally take some of those with me. So thank you so much for sharing all of this information. This has been I feel like I've learned a lot just listening to you talk. So thank you. Is there
I
anything?
appreciate that.
Yeah, thank you.
Well, I would like to thank you very much for having me on. It really means a lot to me. I love doing this type of stuff. I'm still learning how to kind of put myself out correctly. So I apologize if I seemed nervous or repetitive.
No.
Um, I wanted to thank Vicky Weaver for dropping my name to you,
Hmm.
because I know that she recently did a podcast.
Hmm.
So thank you, Vicky. I wanted to thank Brittany Dennis and Jen Kirkarian for being such amazing and kind-hearted friends and doctors. And I wanted to thank Naomi Watt for all the help she's given me.
Great. Thank you for that. Okay, well, that's it for today, and I guess I'll end the podcast here.
Thanks for tuning in to Just Medicine.